and welcome to my channel, Silver Lining, where we look at the benefit of being resilient in the face of storms in life by focusing on the silver lining, the positives of things that are happening around us, having a heart of gratitude. My name is Peter Abraham. I'm a registered nurse. I'm a husband, a father of special needs children that are now adults, a follower of Christ Jesus, for whom I'm grateful to give me the heart of gratitude and to be a person of resilience. In this opening episode, I would like to talk about the impact of being fired at 61 and a half from being a registered nurse. This was the second time I was let go by a different agency as it relates to my outlook on certain injectable products that you still can't mention on venues like YouTube because of censorship and concern for being shut down. So with that said, let's go over a little bit of background. I became a registered nurse later in life. I'm 61 as I record this video. I went back to nursing school at the age of 50. For 30 years prior, still in my adult life, I worked in the field of information technology, mainly around the Unix/Linux operating system. If you ever watched the movie The Matrix, the Matrix appears to be founded on the Unix/Linux operating system, and they'll show people hacking the Matrix. Well, my last 9 years of information technology, I was involved in IT security, trying to stop hackers and working with small businesses to make their systems more secure. Well, at the age of 50, my wife, Laura, and I went for a rather long walk, and she asked me a very good question. Do you see yourself doing this for the next 5 to 10 years? And while I loved what I was doing, I was at the extreme top of my field. I was the owner of a small business, Dynamic Net, now owned by a company out in Texas. But it was a field that was ever changing, getting more difficult to keep up with as you get older. The customers were looking for more and more cheaper venues and not wanting to, I guess, wrap your hands around that when somebody has experience and wisdom, that has value that can be associated with it. And during that time, we had two special needs teenagers. They're now adults. And we're trying to encourage our daughter to go into healthcare. And so when my wife asked me that good question, I thought, it's time for change. It's nice to be in a comfort zone, especially if you are an expert in that field. And it is scary to get out there and try something completely brand new. So I went to a vocational counselor, had a whole battery of tests that were done, some of which I understood in terms of trying to gauge what skills I would be good at outside of information technology, and others being personality tests I never heard of, such as the Myers-Briggs personality test. Oh, you're an INFJ. What in the world is that? That's a separate video for a time later. Never knew what that was until I had that personality test done. But that test showed I would be have the potential to do good in 3 different fields: public education, I love teaching, healthcare, and counseling. And since we were trying to encourage our daughter to go into healthcare, and I believe strongly in leading by example, which means go out there and lead while you're doing it versus go do that. I think that's the best thing to do. I said to myself, a registered nurse teaches, obviously, is in healthcare and counsels. I can get the best of three worlds if I take this journey. So at the age of 50, after being out of high school and business school for 30 years, went back to local community college, got into their nursing program after taking all of their prerequisites and meeting their clinical guidelines. And after 2 years, obtained my associate degree. It was 3 years total for the entire journey to get that associate just due to prerequisites. And thankfully, it was a very top-notch community college, Harrisburg Area Community College. I went to the Lancaster campus in South Central Pennsylvania, and I was able to pass the nursing boards the first time I took the exam. I did scare myself to pieces because I finished the 75 questions in 45 minutes. I did not know the time. You're not allowed to wear a watch or take any belongings into the area. It's carefully monitored. So when I came out and got to the locker and I got my watch on and I looked at the clock, I was like, I must have failed. No one can pass the exam 45 minutes for 75 questions. The questions range from 75 on the minimum end. 65 of them count. 10 of them are intermixed in that to be practice questions that they're considering adding to future board exams. I forget what the maximum is. It's been a couple years now. Might be 325, but you're allowed several hours to take the exam, and I just thought 45 minutes. I must have flunked out. But within 2 days, having the results published and I passed was a heart of gratitude. And long story short, worked in cardiology for a period of time. Backtracking a little bit, before going to college, cardiology in my last year of nursing school, I was a hospice companion volunteer where I would go to local nursing homes to spend time with the terminally ill. I didn't get to interact with the nurses all that much, but I did interact with the patients who were terminally ill just to get a feel for what that would be like. So when I was in cardiology, and I don't know if it's an age thing, because I was in my 50s at that point in time, or my personality is, I am an introvert, INFJ. But I have a lot of patience with the patients themselves, their family members, the situations that they're involved in. And as my fellow nurses on the cardiology floor, many of them in their young 20s and early 30s, saw that I was very patient, especially with the families. When we would get hospice patients on the floor, they would say, "Peter, you're the nurse." And I took that as a compliment. It helped hone my skills in terms of how to interact with family members who, when you're receiving hospice in the hospital setting, are often far worse off than you are in a home or in a nursing home setting. So I had the chance to learn about how morphine, and we're talking IV morphine, which is stronger, more powerful than the liquid version, 3-to-1 ratio for those that are interested. Uh, isn't that powerful? Doesn't hasten death. It was a lot of lessons learned there. But when the opportunity came up to go work in the field of hospice, did that, worked a little over 2 years as a hospice nurse, and felt it was time to stretch my limbs and grow some more, getting out of the comfort zone, looking at the silver linings of opportunity, and went to work at a local long-term care. Loved what I did in hospice. It's still my favorite field, but you are surrounded by a lot of death. And it's not uncommon to go there and arrive and walk in the door and have a family member say they just passed just before you got there. Or maybe you're there and you're the ones that the family's asking to give the medications and you're giving. And while you're educating the family or calling in refills, the patient dies and you're pronouncing. So I love the field. I have a lot of faith-based stories on that, but it does stretch your heart a lot. And so Here, I took that opportunity to work at a local nursing home, and that was when COVID-19 came. Should have seen it coming. You know, it was in the news that it was over in Europe. Our first resident that got COVID was a 102-year-old with lung disease, already wearing oxygen via nasal cannula. And they had dementia along with a lot of other healthcare problems. And this nursing home took a very interesting approach that I didn't think was wise. All of us who got into healthcare, at least for me, we went in with the heart that we are going to do this to help others. I look at it as a service. I am there to help those who need my help. And I don't have a judgment system that, oh, you have this disease or that infection, or this is your skin color, or you believe this or that, or you whatever. I am there to serve and to help you in the nursing capacity that I can, and to show you the compassion for which I can show you and demonstrate. Compassion is a verb. You show compassion with actions. So when they came to, they gathered all of us together, and they said, we know this is very scary. This is our first patient, a 102-year-old, and we have no idea of how fast this is going to spread through the building. We had 151 residents. We're asking for volunteers around among the staff. We're not going to force anyone to care for these patients if you're not comfortable. I and 3 other registered nurses raised our hands. I can't say I was the first, but if you're not the first, it's like every second or third. So it was, oh my word, Kelly Wisnicki raised her hand. She was the first, and then Carissa Browsey and myself. I don't know if we tied for second or third. And then there was a CNA by the nickname of Sam. So just 4 of us out of scores and scores of nurses and certified nursing assistants. 4. 3 nurses, 1 CNA, 151 residents, only 1 patient to start out with. Now, Kelly took the brunt. She was working 16-hour shifts, but I still remember the day that I came in on a Saturday where they asked me, Peter, would you mind being both the nurse and shortly thereafter, the nurse called, the CNA called off. Could you be the nurse and the CNA? It's no problem. And when I get there, it's like, Peter, the supervisor called off too. Now I'm the supervisor for all 151 residents, the nurse and the CNA for this patient. And it went well. And in 16 days, the patient got better. And no controversial treatment methods. We went through 5 directors of nursing in 7 months. 5. Thankfully, our first director of nursing loved science and tore up the unscientific, I'm going to repeat this again, tore up the unscientific CDC guidelines. That may shock some people. The Centers for Disease sent out unscientific guidelines to nursing homes. It wasn't just that Governor Tom Wolf and Dr. Levine were sending COVID positive patients to nursing homes in Pennsylvania, but the CDC sent out non-scientific, not evidence-based guidelines to deal with COVID. If you ever went into a local nursing home and one of the first things they did is get a thermometer and check your temperature or stuck something in your mouth, if you're an elderly person, 65 and older is typically for geriatric, that is not science. Fever in the geriatric population is an extremely late sign. So when you talk about somebody who is not healthy, they're not doing well, when you're talking an infection, there are early signs, there's middle of the road signs, and there's very, very late signs. So when an elderly person has an infection and they get a fever, that is an extremely late sign. that either A, the infection is going to kill them, or B, they're going to recover within a few hours to a few days. So if you're checking for temperature, and that's going to be your primary method of detection, you're discovering the infection late. So out of 151 residents, and over time they all got infected, the first wave of the pandemic was extremely infectious. We went from one patient, the next thing we had 2, 3, the next thing you know, we had a zippered unit of 40. Thankfully, we had no more than 40 at a time, but it went through the entire building. And out of those 151 residents, maybe 2 of them spiked a fever. Can you imagine how many people would have died if we went by the unscientific, not evidence-based practice that the CDC was telling the nursing homes? And to give you an idea of the difference between the two, most nursing homes in our area of Pennsylvania, South Central PA, tore up the CDC unscientific guidelines and went with evidence-based practice. So what is evidence-based practice? And I'm going to tell you the results momentarily. But evidence-based practice for wave 1 was looking for, was the resident lethargic? So lethargic is tiredness on steroids. Now, under normal circumstances, when you're tired, and we've all had cases, especially for an adult watching this video, where, oh my word, you just hit a soft surface. Sometimes it can be hard, and you're asleep in seconds. You are tired. Well, imagine being that tired, but you want to stay awake. Maybe you have a drive and you need to get to where you're going and you shouldn't be driving, but you're in a catch-22. Or maybe you're babysitting and you don't want to have trouble. You really care about the baby you're babysitting or the young child. Or whatever the case may be, you have to stay awake. Well, lethargy is you're tired, you're fighting to stay awake, but the tiredness is taking over. And you may have seen this if you've been around sick people, where they get a word or two out and then they're asleep. And then they're looking up and they might try to speak and then they fall asleep. That's lethargy. So you're looking for lethargy. You're looking for delirium. So somebody who's delirious, there's a change in their personality. We were also looking, we were assessing a minimum of every shift, sometimes several times a shift. And that would be, the pulse ox. I'm not a big, in hospice, we don't do a lot with the pulse ox, but, pulse ox on the fingertip. And if we were seeing a 5-point change in oxygen saturation, we're going to swab for COVID. Personality changes, we're going to swab for COVID. We're listening to your lung sounds, and if your lungs were clear and now they're wheezy or diminished, or we're hearing crackles, we're going to swab for COVID. So we did early detection, early isolation, and because we did that, early detection, early isolation, early treatment, contacting the physician right away to get those orders going. Out of 151 residents, we lost 3 people. 2 of them in the building, 1 that we sent out to the hospital. We're treating everybody in place. And the local nursing homes around me that threw out the unscientific CDC guidelines, and these were before any vaccines were available, were seeing either 100%, all of their residents recovered, all of them recovered, or they lost 1%. Now, all human life is sacred. I mentioned I'm a follower of Jesus. All human life is sacred. But for those of us who were working closely with the doctors, and I was one of them, when you saw the radiology reports for what they were calling COVID pneumonia, you were seeing pneumonia. You were not seeing something different than pneumonia. You were literally seeing pneumonia. And because they were tested positive with COVID, they called it COVID pneumonia, but it was pneumonia. So because I don't want to go too much into this video about bashing a particular area, because we are going to be talking about what happened with getting fired twice, once most recently this year. I did need to go about the background that in our area, we were seeing 99 to 100% recovery rate. 102-year-old recovered. Cancer patients recovered. Diabetics recovered. People on dialysis recovering left and right. Some of my coworkers were infected. Even the best of us that were using the N95 mask, the appropriate PPE, were getting infected and recovering. We would hear on the news people were dying left and right. People were infected left and right. I was so frustrated with the media because they were not talking about the recoveries left and right that we were seeing in the field. And I know there are going to be people commenting on this video that worked in a hospital setting, and I once worked there too, saying, well, we were seeing a lot of deaths in the ER and we were seeing a lot of deaths in the ICU. And my commentary to that is I mentioned I was going to share, what about those nursing homes that went with the CDC guidelines that were using the temperature as their main method of detecting COVID? There was a local nursing home in our area that obeyed the CDC guidelines to the T. They didn't throw them out. They had a 50% death rate, 50%. They lost half their residents because they didn't say, wait a second, that's not science. They literally blindly followed the recommendations before engaging their brain, where as registered nurses we're supposed to think critically. They dropped the ball, in my opinion. Those nursing homes, and many tore up the guidelines, saw close to 100% recovery rate. So getting back to the hospitals, the ICUs, and the emergency rooms, if you detect an infection late, if you have a urinary tract infection referred to as a UTI, and you wait until it's up into the pyelonephritis, you get urosepsis. Sepsis that started out as a UTI. You're going to be in the ICU and you could die. If you wait too long to catch any infection and you wait to the last minute to go to the hospital, you're going to be far worse than if you detect it early and treat it early. So after everything that I witnessed, and I love science, and during all this going on, and witnessing everything that was going on, and reading about how they were developing the vaccines, and this is not a video to bash the vaccines, I knew that the vaccines were at best were going to have the efficiency rate of the influenza, the flu vaccine, which is very low. And I was also troubled that mRNA technology, which was never used for vaccines, when you were reading the initial scientific discussions, and they were talking about the pros in these scientific discussions, they were equating it to gene therapy and the type of therapy that's used to treat cancer. So when you watch these commercials on TV where they talk about if you have breast cancer that has this certain gene as part of your breast cancer, that you might be a candidate for this immunotherapy. That's literally the language that they were using. And I'm thinking to myself, how are they going to do this on a mass scale? Because they're not going to be testing these people. So I had a lot of question marks about that never were resolved. And thankfully, I made the decision not to get vaccinated. So after lasting 7 months in this nursing home, we went through 5 directors nursing in 7 months. The fifth one, all of these directors were very good, but it was a lot of pressure from the state and from the the nursing home administrator. We were on our second one. The very first one was very pro-family. The very second one was, for lack of better words, was not pro-family. in terms of if your family member was dying, they would not easily let the family member come in and spend time with their loved one. And granted, we only had 3 people die, but if they're close, you want them there. And not, we had people that died and they didn't have COVID. So I felt it was time to leave, and I love hospice, and I went back to hospice. And because I do my best not to burn bridges, give appropriate notice, the company I left hospice for hired me back. Now, shortly after being hired there, the vaccines were rolled out, and there were no mandates, and I made the decision to remain unvaccinated. After all, I was on the front line. I cared for 151 residents at that nursing home. I still remember the day where the entire COVID unit nurses called off. And I walked in and they said, "Peter, don't panic. You're getting the keys to 3 medication carts. You're responsible for 151 residents, and you need to give an entire shift's worth of medications to 40 COVID, all geriatric patients that were in the zippered unit." I still remember that. I was on the front line. I was on the front line where we had a hospital that was not supposed to send over positive patients in spite of Governor Tom Wolf and Dr. Levine. We were trying to sway them as to, like, if they test positive, can you hold? Can you give us time? Because our zippered unit could only hold 40. And we had a cancer patient that we were waiting on test results back. We didn't know they were positive or negative. And I'm doing the admission. So I'm in with that patient. And because we were told that they were not in the red zone, I'm just wearing a regular surgical mask, not an N95 mask. So the regular surgical mask, they have the opening on the sides. They're not airtight. And even on the N95 mask, viruses get through. Electron microscope to see them. Even an N95 mask is not going to stop them. We had nurses wearing a N95 mask getting affected. I shared that earlier. And so here I am admitting this patient. They're coughing all over. Well, lung cancer. One of the symptoms of lung cancer is coughing. I'm getting coughed at right in the face, and you can't always time, like they're not timing their cough. It's spontaneous. I'm trying to be very careful where my face is directed. But there's times where, like, I'm going to listen to their lung sounds, and so you have the stethoscope there, and there's only so many inches on your tubing, and your face is near their face, and they start coughing like crazy. I'm going to treat them like a human being first. Or I'm going to repeat that. I'm going to treat them like a human being first. I'm going to treat them like a human being first, and not jump as if I'm afraid of them. When I worked in cardiology, I worked with AIDS, HIV positive AIDS patients. And I made it a point to hold their hand because they are a human being first. Can't stress that enough. So I went back to the field of hospice, not afraid, because I worked on the front line with COVID positive patients. Didn't get COVID. Was not afraid. Well, as time went on for this hospice agency that was purchased by a very large corporation that's now involved in a lawsuit from the government in terms of whether they can merge again to become even bigger, they create a dichotomy. If you're vaccinated and you come into the office, you don't have to wear a mask. But if you have unvaccinated, you have to wear a mask. And even before then, if you had any unvaccinated staff, everybody had to mask up. And I still remember my managers not being supportive, mumbling just loud enough purposely so I could hear. You know what, with Peter holding out, and there were a number of CNAs holding out, you know, we're never going to get to where we can be mask free. That wasn't my fault. That was the corporation making that decision. It later came out this year, maybe it was last year, came out. The social distancing rule was made out. Mask never really made a difference. That was my gut feeling based on experience, anecdotal. Evidence-based practice comes out of anecdotal that you do evidence-based studies on. But then they changed it that you could come in and, vaccinated, don't wear a mask. Unvaccinated, wear a mask. Fine. Then they had a change where out in the field, if you were vaccinated, you did not have to wear a face shield. But if you were unvaccinated, you have to wear a face shield and the appropriate face mask. And this is what got me in the problem with the first agency. So when I worked at the local nursing home, I'm obeying all the CDC rules, which we didn't follow the rules when it came to detection, but when it came to PPE, personal protective equipment, I was following the rules. And that is have a face shield with the N95 mask. And I didn't know at the time that I had adult onset asthma. So what happens with that is a face shield restricts the amount of airflow that you could breathe between the shield and your mouth. It's restrictive. And in a very hot and humid room, I just literally didn't get the air volume. Ended up having a panic attack. And the next thing you know, I'm ripping everything off my face and pulling it off. And wow. So my doctor happens to be the medical director for this hospice agency, wrote me a medical exemption to a face shield, which, by the way, the CDC actually came out and said a face shield offers zero additional protection because the virus isn't smart. It's not going to just stop at the plastic and not go underneath or around. It's going to get contained within and actually be kept in that area, and you'll breathe it in more often. So I had this exemption, and that was given to HR when I got reemployed by this hospice agency. But when big corporate was up and visiting, I made the mistake of being me, and part of being me is I am honest and I am transparent. So when corporate was up and they sat down with me, the lady from corporate, and said, Peter, how do I like being a hospice nurse here? And I love hospice. And I said, do you have any, she asked me if I had any questions. Well, I said, yes. I'm on call this weekend and I'm going to see a patient that belongs to another nurse. And I've never seen the patient before, but they're at a nursing home and I have two issues. I said, issue number one, they need a up-to-date COVID swab test that's within 24 hours. And here, this is several months past a lot of the waivers that were there. And they moved to once a week testing. So my test was a week old. This nursing home wanted within 1 day. I said, how do you want me to handle that? And I said, the second issue, which is to me more concerning, is this is a nursing home where their published policy that when you go into this patient's room and they were COVID positive, you had to wear a face shield and a mask. I said, I'm going to follow their rules, but I have a medical exemption for the face shield. And my concern is most nursing home patients crank up the temperature. Am I going to walk into that room and have a panic attack? I can't predict that, but I'm a compulsive planner. So what if I do? What do they want me to do? Do they want to assign this to another nurse, or are they okay with me going in and just wearing my glasses, which the branch office said, Peter, you have glasses. You don't have to wear the shield. And my clinical manager, who was promoted to the director of hospice, actually went out with me during these policies where I'm just wearing my glasses. I'm not wearing the face shield. She was there and no warnings, nothing that I was doing anything wrong. They knew the policy too. It was like, Peter, you got glasses on, you got the eye protection, which I never understood because it's not like COVID focuses on your eyes. It's an airborne virus. And I know any of you who study science, and I love science, yeah, our eyes are breathable. I understand that part. But there's no science that has stated you get COVID through your eyes. Anyway, long story short, this lady asked, well, how have I been handling this with all my patients to date? Because you're unvaccinated. And I said, well, my managers know I have a medical exemption that was given to me by your medical director for this branch. And I've had that for some time. And so I always wear the appropriate mask. So if they were COVID positive, I'm wearing an N95 mask. If they're suspected for COVID, I'm wearing an N95 mask. If I don't know, I'm wearing an N95 mask. If they don't have COVID, I'm either not wearing a mask or I'm wearing a surgical mask, depending on what else is going on scientifically. And she goes, but you're not following corporate policy. She called HR. I was immediately suspended with pay, pending an investigation. Long story short, 1 week later, after I'm going through all the legwork, they said, we want you to fill out for FMLA. They had me do a lot of tests to get a medical appropriateness above and beyond the medical exemption from the doctor, meaning chest x-rays, pulmonary function test, and more. Got all that done, 3,000 out of pocket, and was terminated for not following the policy. And later found out that was used to pressure the remaining unvaccinated staff to get vaccinated, all but one. So I was actually afraid to go back into hospice, any type of traveling nurse, because we faced the barrier of not only will the company hiring us, will they have an exemption for me, but where am I going? Because as a hospice nurse, I might be going to a personal home, or I might be going into a facility. So I went out there and I got hired by a local hospice agency that actually worked with me to get a religious exemption for the COVID vaccine, because at that point in time, the Harrison-Biden administration put in the vaccine mandates that have been since removed. And so they worked with me to get a religious mandate, and things were going great. I was well loved by the families. I love my coworkers. I love my staff, and a lot of work-life balance. But as things were going, and I became, for lack of better words, the community nurse, I was called on to be an educator. I would develop education programs to help our referral sources, to teach med techs on how to administer meds, or to not be afraid of giving the comfort medications on a timely manner. You're not killing the patients. These medications are there to keep them comfortable, not to have them die faster. So I became the resource person for these. Please apologize as I just double checked the one monitor still on. But I became the community resource person. So I'm getting more patients on my caseload. And this agency was bought out by another big corporation. That's the one downside to hospice. If you work for a small nonprofit or even a small profit, and they put patients first, wonderful. But the larger agencies push the numbers. And so this was no different. So I went from having a very manageable caseload, working 40 to 45 hours a week, highs of 50, which was very doable, to where I was averaging 50 hours a week, averaging. Some weeks would be 60 or 70 hours. Some weeks might be 35, but the average was 50. And 22 was a very hard year, 2022. My father-in-law died after a booster. A year later, my mother-in-law died. My biological mother died a few months after her, so 2023 was a lot of deaths. And lots of patients again. This is hospice. And so by August of 2023, I'm facing burnout with the 50 hours a week. Loved what I do. Loved and adored the educational aspect. But there's a lot of pressure. I would spend an average of an hour and 15 minutes to an hour and a half with every patient. especially my home patients would probably be an hour and a half. My facility patients might be an hour. It's not that they matter less, but if I'm dealing with somebody that has a cognitive disorder and they're in a facility setting, well, I can spend some time with them. Uh, if they're suffering from any type of psychosis or agitation, sometimes I have to get out of their way. I'm not there to distress them or cause them agitation. Sometimes I need to step away. So I would spend time where I could. And a lot of these families had a heart for me. They loved me as their nurse, and they say, Peter, we don't want anybody else. And that's a boundary you have to be very careful with, and I try to balance that. But they would also tell me that if somebody came in my place, they were in and out in 15 to 30 minutes. And that was the pressure from the company that I was working for. Well, Peter, you wouldn't be dealing with this 50 hours a week on average if you were quicker with the patients. I still remember my one patient was very difficult. They were an addict. So there were lots of medications in the home along with alcohol and other miscellaneous drugs. I'm not there to judge, I'm there to treat. And that required counting the medications we provided every single visit. So just counting the multitude of narcotic medications, there were a number of them, was 15 minutes. And to me, if you're going to count the medications, you need to be able to do something with those numbers. So I'd actually have a section of my notes that would compare. This is what the person had last visit. This is what they have this visit. This is how much they've used in between. And based on the doctor's orders, were they either overusing, underusing, or appropriately using? How else can I keep the doctor up to date as to whether we have an abuse situation or not? This was a patient where on 2 separate occasions I came into their home and the patient is completely passed out, alive, unable to be awakened, and family freaking out as to what was going on. So my visits there, just doing the counting was 15 minutes. The comparative might take 5 to 10. And then I'd spend an hour or so with the patient and the spouse, the daughter, other people who lived in the home. And I take the time. One of the persons who lived in the home was the landlord. It was an interesting situation. Took me outside the one day to share some of the drug abuse issues that I had to share then with our social worker and our team. That takes time. If you really care about people, you have to spend time with them. And I spent time. We have the system we're using, home care, home base, point click. It tells you the time that you're in the home. It was our payroll system on top of it. So if the nurse took my place, when I looked up the history of the visit, I could actually see how much time were they in the home. So I saw that one of the nurses spent 17 minutes in the home. I'm like, okay, even if you sped count, like you sometimes, like I have a pill counter. I have a pill counter you can take and just, push the pills in, and then you can push the pills back in the container and get an accurate count. A number of nurses will eyeball a container. Okay, that looks like X pills. There were this many pills last time. I guess that's that. This is narcotics. I take this seriously. I'm counting. Maybe they eyeballed it, but even if they did it in 10 minutes, what did they educate for 7? Assessments don't take that long. If you're a nurse watching this video, you're going to get to the point where you can do a complete a head-to-toe assessment if they have no wounds in minutes. It doesn't take that long to get a manual blood pressure and do the rest of the assessments. But where was the education? Where was the compassion that is a verb you have to act on that takes time? And I would have the management staff saying, Peter, be like this nurse over here that spent 17 minutes, this nurse that I love. They were a very pleasant person, but they would brag. They still remember the one time they shared the longest time they spent with the patient was 45 minutes because a spouse demanded it and they were upset. They said that their average is 15 to 30 minutes for a visit. That's not me. I am not a cookie cutter. I'm a human being too. And I believe the people that I'm going to see that are terminally ill, 6 months or less, they deserve my time. They deserve my time. They need me to listen actively. I'm doing a lot of talking on this video, but if I was your nurse, for example, I'm spending most of the time listening. I'm asking a lot of questions and taking the time to listen. And a lot of questions followed up on what I'm hearing to validate what I'm hearing. I'm validating your feelings and your frustrations. And then I'm making phone calls in front of you. So that's part of what I did too, is I documented in the visit. I made my phone calls in the visit. So there was complete transparency of everything going on, and that takes time. So come August of last year, I'm asking to go part-time. No one's listening. I'm begging to go part-time come September, October, and they're saying, well, Peter, what are you looking for? And I said, can you at least take me down to 32 to 40? He said, 32 to 40, that's full-time. You're already full-time. We're not making any change. Well, come January of this year, I had it. I ended up falling for a situation, and that'll be a time for another video. This one's already running longer than I thought. But I ended up giving notice. I gave 2 weeks. They accepted it immediately. That happens sometimes. And I left. And was hired by another hospice agency. It was a little bit leery. I had a wonderful opportunity to work for Penn State Health at Hershey Medical in Hershey, Pennsylvania, as a patient care coordinator. It would have been a marvelous change, completely out of my comfort zone. I spent some time shadowing. But I fell into the trap of I love hospice. Maybe I should stay in my comfort zone. Went to work for a medium-sized agency that had a lot of services like music therapy. That's very rare, at least in our neck of the woods in Pennsylvania. And thought, this is a brand new opportunity. I'm going to make every effort to see the silver lining in everything, and to not repeat any mistake at all that I made. Because we're human, we make mistakes. One of the mistakes I made at this agency is that the 50 hours a week is if there were on-call events that were too close to my time to clock, I can't say clock out, but my end of day, I would refuse or say no. And so here I was doing everything to say yes. Even if I was exhausted, I'm doing everything to say yes. And so I got hired, and that was in early February. They accepted my religious exemption, even though the mandates are over. And I thought, this is going to be a good change. Within less than a month, I'm receiving a gratitude card from the CEO, how much of a wonderful difference I'm making with the attitude, looking at silver linings, on how I'm helping with the staff, on how I helped rescue a number of situations where the patient was in crisis and no one knew what to do. But because I had 6 years experience in hospice, I was able to come in calmly and here's what we're doing. It works. Surprise. And I'm thankful. But what ended up happening is just a little bit of background. In the previous agency, one of the things that shocked me is we've had an explosion from 2022 forward, especially 23 and 2024. There's been explosion of certain types of cancer that some doctors are referring to as turbo cancers. And I was very surprised when a doctor that I worked very closely with at the previous agency, one that was 50 hours a week or more on average, said in one of our meetings without me, I always kept my mouth shut because this is a very sensitive area and I got let go once. I don't want to get let go again. I would keep my mouth shut. But the doctor said, when asked by another staff member, why are we seeing all these glioblastomas and all these rare cancers? And the doctor said, side effect of you know what. And he said you know what. I'm not repeating it on YouTube because of the algorithm. And by the way, if you're enjoying this at all, please like and subscribe. I asked that late in the video. But the doctor said this to the entire staff on record. Dr. Patrick Gilhall. And so try and say yes, getting back to the situation. One of my patients was a glioblastoma patient who in his early 50s, younger than me, there was a sad case, unbelievably healthy, exercise, wouldn't even have known that cancer existed, but was found out after an accident involving a sport that this person was involved in, and after scan showed very aggressive, non-treatable cancer. And for better or worse, I try to be transparent when one of the family members asks, this doesn't make any sense. Does it run in the family? Very healthy person. What's going on? And I made the mistake of sharing with the family that this doctor that was local to the county that I'm serving. We're not talking about a YouTube doctor. This is a very local doctor, a very well-known doctor in the area, said this. That got back to the agency. The next thing you know, they're saying, Peter, we have to have a meeting. And they never told me what was going on. We have to go talk to the nurses at this building. It was a nursing home. And they were like, what? They're confessing things they did that they had no control over. The patient had a seizure. They didn't have a sign posted up to when they call for help, so help seizure. So here, when the paid caregiver witnessed a seizure, the paid caregiver did what anyone who didn't know what was going on: help, help, and they're screaming for help. And here, the medication to treat was in a fridge that they had to run back and get. So they thought that they were under the gun because the company that owns this hospice, owns the facilities in question, good or bad, I don't know. And so they thought they were the ones being investigated when it was me. And it was like, no, did Peter say anything? And they were like, Peter did everything correctly. I collaborated with them. I worked the battle plan with them and the administrator and the director of nursing as to how to reduce seizure risk and how to comfort everything, made all the phone calls, put in a lot of time after hours. And but then it was like they would be doing spot checks. Peter, we need to be with you and we need to hear what you're telling the families when you're calling the families for updates. I guess they had the fear that I'm on the phone when I'm calling the families at the different facilities. Don't get this or don't get that. And they don't understand. This was a one-time situation that I was asked a direct question that I answered transparently and honestly. And even looking back, I don't want to lie. So if I'm asked the question again, just so you know on YouTube, I'm going to tell the same thing. Because there are other doctors, he's not the only one, he was local, but there are other doctors saying this. And long story short, June 14th, I'm with one of my patients who, prior to even walking in, they're at the same facility with the glioblastoma patient. The facility forewarned me. This patient, a retired hospice nurse, is asking to be knocked and kept unconscious. Now, there is a word for that, palliative sedation. They're being asked to be knocked unconscious. Could I go in and talk to them? And I went in and I talked to them and I educated them. They're not using the medical term palliative sedation. They're using, I want to be knocked out. I can't take this anymore. And I've used palliative sedation before, mainly as a form of symptom management for severe cases. But this person, when I say symptom management, I'm talking about respiratory distress or pain or intractable nausea and vomiting. I've never used it before for pure emotional distress, but emotional distress is a symptom. And even though we had this person's symptoms outside of emotional distress, I want to minimize that, very well managed. If we went any further up on the meds, we'd actually be palliative sedating. And we were not intentfully we weren't intentfully snowing them, which is purposefully making them unconscious. So I explained the pros and the cons. It's legal in all 50 states. It's not considered euthanizing, but you won't be eating and drinking. And that will make you go faster just on that fact. This is what the patient wanted. Didn't make any promises. I talked to their medical power of attorney, who was in agreement. Didn't make any promises. Talked to the director of nursing, telling them, I'm not making any promises. I'll educate your staff, for which the director was very grateful for. I would be the one to initiate it. I would stay until it was working, and I would stay longer to make sure it's working. Remember, I don't mind the time. And we have to get the okay from the facility. We have to get the okay from the medical doctor. I would get the medical doctor last. Because if the facility said no, because hospice is rarely the primary caregiver, we would not be able to move forward. So after I left the director of nursing, who was going to check in with her management, I let our team know what was going on. And I said, this is going to take a village. It can't just be me. I'm going to be the initiator if they get all the okays. But we're going to have to work. We're going to need social work. We're going to need a chaplain. We're going to need everybody involved because it's very emotional. It's legal. It's not euthanizing, but you're purposefully putting somebody in a state that they will never wake up from until death takes them. And within minutes of sending out that encrypted email, I get a call from my clinical manager. Please pardon my language. I normally don't say certain words. What in the hell were you thinking? We can't do this. You're crossing the line. And I was yelled at and screamed at. This is crossing the line. You need to come in at 3 p.m. today. See your other people, come in at 3. So I completed that visit. I had other visits to make, including recertifications visits. I completed them. I put in the time. I did my best to not think about what was coming at 3. I kind of knew. And I went into that meeting and I was told, you're being terminated. I don't know if it was because of advocating, because I've been told in the past by managerial staff that I advocate too strongly for the patients for whom I care. And one of the changes that's been happening in the field of hospice, if any of you work in hospice and you've worked for big for-profit corporations, you will know what I'm talking about. One of the sad changes that I've been seeing more in 24 than in 23 is we've been moving from patient-centered care, where the patient matters, their family matters, their power of attorney matters, their friends matter, to referral-centered care. And the difference is the referral is where are you getting the admissions from? Who's sending you the hospice patients? And for a number of hospices, it's the nursing homes, the skilled nursing homes, the assisted living facilities, the personal care homes. And yes, the hospitals too. They're sending over the referrals. So these referral sources are being told they get to dictate their terms. And their terms are not always financial. They get to pick what staff are allowed to provide care. It could be as simple as they don't want a male nurse. I've dealt with that before. And sometimes it's okay, and sometimes it's like, okay, it's a form of discrimination, but I'm in it for the patient. I'm not litigious. But they could also be a matter of they're going to say, we don't want somebody that is unvaccinated or has certain views, or somebody who advocates for the patient. Like there's a nursing home in Lidditz, Pennsylvania that I was told I'm not allowed back in because the nursing home, from a ethical perspective, was keeping the patient hostage. The family wanted to take the patient who was dying. They didn't have that much time to get them home near Philly. They needed a doctor to come in and say, let them go, or a doctor to sign the paperwork. They could be discharged. There was nothing that they were doing. They're not receiving treatment. They're not receiving therapy. They're on hospice. Let them go. And they were refusing. So I made the mistake of thinking that if the door's closed, nobody's on the other end listening. And I'm whispering to the family. And I said, you need to tell them that you're going to call the police, and be prepared to do this if you mean what you say, because this is a crime. And thankfully, they didn't have to go that far. What ended up causing me, I can't go there anymore, by telling the family the truth, they were able to get expedited to go home, and the patient was able to die at home. And I will advocate that far. And I'll leave it at that, because this video has gone on longer than I ever anticipated. And if you've been with me this far, thank you so much for watching. Future videos will go over how being let go at 61 and a half, unexpectedly, loving the field, what happened next. So if you're interested, I hope to put out a video on a regular basis. I hope to go over how to prepare any of you. And as I say this, I want to be big-headed, like it's not me preparing, it's God. But I want to give over some thoughts that have helped me, that may help you. Look at silver linings. And I thank you for your time.